Hi, this is Dr. Len Calabrese. I'm a professor of medicine here at the Cleveland Clinic Lerner College of Medicine and the director of the R.J. Fazenmeyer Center for Clinical Immunology here at the Cleveland Clinic. I just got back from EULAR 18 in Amsterdam. Fabulous meeting where I learned a lot. And right now I'm going to be discussing underestimation of cardiovascular events by cardiovascular risk scores in psoriatic arthritis patients. It's by Lamb and colleagues. So the bottom line of this is that similar to other forms of inflammatory arthritis, this study showed that a variety of cardiovascular disease risk scores significantly underestimate cardiovascular risk in patients with psoriatic arthritis. In addition, adaptation of the EULAR recommendations only partially accommodated that to a moderate level. So let's dig into this, and I found the study quite interesting. The reason is that in terms of importance, the accurate estimation of cardiovascular risk is important in patients with psoriatic arthritis since they do have an elevated risk of cardiovascular events. So in our practice, we want to give accurate modeling and predictors to our patients. And as I will show you, current risk scores, no matter which one you're picking, is likely to underestimate these risks. So how did they do this? Well, first of all, these investigators collected data from 2 Hong Kong cohorts of patients with psoriatic arthritis. The discriminatory ability to predict cardiovascular risk was estimated by the area under the receiver operating characteristics curve. This, plots sensitivity versus 1 minus specificity. The perfect point is, at the 0 x-axis and at the top of the y-axis, where it would be a perfect test. 4 different cardiovascular risk scores were utilized. They were the Framingham risk score that we have had for many years, the Q risk, the heart score. These are European variants, one from UK, the other from European cardiovascular groups. And then finally, the more recent American College of Cardiology, American Heart Association, 10-year atherosclerotic cardiovascular disease risk score. In previous iterations of EULAR recommendations, there has been a suggestion that to take the existing cardiovascular risk score and multiply it by 1.5, which was proposed for patients with rheumatoid arthritis. So the hypothesis was, let's take that recommendation, which basically ups the ante and increases the risk by a factor of 0.5, and apply it to psoriatic arthritis. So the primary outcome was first cardiovascular events. And this actually is very important because it's a little non-traditional. They included a wide variety of events, including MI, angina, stroke, heart failure, bypass, also implantation of a pacemaker, defibrillator, peripheral vascular disease, and a number of others. So it's a little more broad, a little more sensitive index of cardiovascular disease. So what about the key findings? Well, it's a small study. 228 patients were recruited over a decade, from 2006 to 2016. Mean age of almost 49 years, 54% male. Over a mean period of follow-up of 6.7 years, 30 patients experienced a cardiovascular event. So then they got baseline data available to calculate all these risk scores: Framingham, Q-risk, heart score, ACA, HA, in groups of patients where all of these data were available. As you can see, the majority of patients had data available for all of these calculations. At baseline, those who went on to experience cardiovascular events were significantly older. They had higher prevalence of diabetes, high blood pressure, and elevated triglycerides. That was statistically significant. As expected, their risk scores were significantly higher at baseline. However, many were not identified in the highest risk categories. So if you look at the identified risks at baseline, you could see that 63% of the patients in Framingham fell into high-risk groups, where Q risk was 20%, heart score only 13%, and the more recent ACC-AHA 46%. So now applying the EULAR recommendations, this hypothesis-driven fudge factor, if you will, that increased Framingham to 80%, Q risk only to 36%, heart score 27%, and ACC-AHA to 57%. These findings demonstrated that 4 risk scores utilized in this study, even after adjustment, underestimated the cardiovascular risk among patients with psoriatic arthritis. So how do I interpret this? Well, first of all, I think it's an interesting, attempt. And if you actually go back and read the original EULAR recommendations, it's not all patients with rheumatoid arthritis, particularly those with longer disease and higher risk prognostic factors of their rheumatoid are the ones that where we recommend adjusting this. So I'd wonder, well, maybe if they just focused on patients with psoriatic arthritis that were moderate or severe, you may have come out with another answer. Secondly, while this is intriguing, and I actually believe in the conclusions, this is a very small study, very small number of events, and they cast their net so broad, they use so many cardiovascular endpoints. I would like to see it to be done more traditionally with just MACE events. Lastly, you should ask yourself, well, why is this? Why do all these risk scores underestimate cardiovascular risk in patients with rheumatic disease? I think the answer is this is classical risk partitioning. Those scores are driven by the risk factors in the general population, which are generated largely by we live in a lipid-rich world, lipid-driven, high blood pressure-driven. We live in an inflammatory world, and not all of these incorporate as many inflammatory markers. I will continue to look at cardiovascular risk predictors of all sorts as underestimating, and I will continue with my practice. Every single patient that comes to the Cleveland Clinic with an inflammatory rheumatic disease, our electronic medical record says, has this patient been evaluated for cardiovascular disease? Have they been referred to preventive cardiology? I think we need systems to make sure that each and every patient is followed for this. So overall, interesting paper, a lot of work to go.